हेलो।
Good morning, all the participants. We will start program soon within 10-15 minutes. Thank you for joining.
अच्छा हुआ सर राउंड टू में।
हमको बता देखा है ना Yeah. Nice.
या तुषारहार धवला या शुभ्रवस्त्रापिता या वीणा वरदण्डमण्डितकरा या श्वेत पद्मा या
Now invite Dr. Vanda Shah, head of the department, to give deliver a welcome address.
Very good morning, everyone. A warm welcome to the PD program. Warm welcome, sir. And our two other resource persons, Dr. Hardik and Kavin. Actually, there were a lot of deliberations before we came to this, this topic of tackling medical emergencies in dental practice. Any specialty, whatever specialty of dentistry, we are bound to encounter emergencies, be it a simple local anesthesia, extraction, surgery, or a simple stress, patient sitting on the dental chair and anxiety, that can lead to a syncope in a patient. So, knowledge is wide. Everybody has all the mobile phones, but knowledge with wisdom and experience is what we thought was everybody here needs, need of the hour is we don't need to take lectures for all of you now because everything is in your hands now, whatever you want to read, whatever videos, but the practical tips, what comes from wisdom and experience. So, Lakhani sir, no better person than Lakhani sir. He's now Professor Emeritus here. I mean, he's been associated with the medical college since its inception, 2003, yes. So we thought of him, no better person for us to learn from his experience, his wisdom, and the knowledge he will share today. And I'm sure all of you will take away some tips from whatever he's here. They've taken a lot of pains, they've got many people to, give a hands-on, to even demonstrate how to tackle certain emergencies in your clinic. So I'm sure all of you will take something from here. Once again, a very warm welcome to all of you. Have a nice day.
Before I invite sir for the talk, I request Dr. Tarak Mehta to give introduction also.
Morning. So, Dr. Jitendra Lakhani sir is the emeritus professor and consultant at lifestyle medicine, SBKS Medical Institute, tuition in Sumandeep Vidyapeeth. With over 44 years of experience, sir has served as a head of the department, vice dean, and PG director, and guided numerous MD and PhD students. Sir is gold medalist and acclaimed academician. He has over 100 plus publications and 150 plus conference presentations to his credit. So as today, as a resource faculty, he bring this vast experience to counter the medical emergencies we face in our dental practice. So I would like to.
Thank you, Dr. Tarak. Today's session will be divided into two parts. After first session, we will have a short break and then we continue with the second session. I now request sir to take the stage.
Folder. बस हाँ presentation. Okay, good morning, everybody.
Good morning.
So the title which is being given, I think Dr. Rashmi, she suggested this title, and I felt that the title suggests so many things. So the title is Calm Within the Storm. So whenever the storm would come, storm would be something like an emergency. And one of the best part about it is that if you remain calm, you will be able to tackle such a storm. So how we sort of would be tackling dental emergency, that would be, say, the topic which I am going to sort of deliberate on. Next slide, please. So with me, Dr. Hardik is there. He's a resident in medicine, and Dr. Deepika is there. He is in charge of our lovely simulation center. So what we are wanting to do is that we will be posing some of the case scenarios. So what Madam Golokia told to us was that she gave a lot of list of the emergencies which would be there. As Madam was trying to say, what I thought was that let sort of it should not be just like a lecture, but it has to be an interactive session. So what I request all of you that you do just try and sort of be interactive. I might be asking some of the questions. Don't feel shy that you would be wrong. Say at my level also we might be wrong at certain points. And one of the other things which is also being true is that there are a lot of controversies also. See, nowadays the knowledge is expanding, and what you might be finding, whatever I'm trying to say, you might find something different at different places. And whatever videos or whatever things which you will be seeing on internet, they might not be up to date. So what I would be trying to do, I might be a little critical about whatever the videos which have been there, where see what should be really being done. And then see when I was being told, say earlier I was taking lectures in the college also. And one of the topic which was being given to me was unconsciousness, how to tackle unconsciousness on a dental chair. Now, when say I look sort of now, what I feel is that trying to give lecture in form of that these are the causes of unconsciousness on a dental care, or these are the emergencies which will be done. It's not going to make you wiser. Because suppose if the patient is having epilepsy and if the patient comes to you, at that time you would not remember Dr. Lakhani saying that, okay, one of the cause of unconsciousness was epilepsy and you should be asking about this. Rather than if you try and see the case scenarios, and see, believe me, whenever you would be getting a case, different cases would have different sort of, uh, they are a different textbook, which might teach you some lessons. So it's not that you would get a typical patient who would be having only epilepsy or who would be having only excessive bleeding. So what might happen is that patient might be asthmatic, patient might be having obesity, patient might be having diabetes, and then he comes for dental extraction and he ends up with emergency. So what exactly you would be doing? And then when we say person has become unconscious on a dental chair, there are 150 causes which might be there. And what exactly is to be done? What we expect? We don't expect that you should be trying to sort of manage the emergency which a physician or a cardiologist is supposed to do, or intensivist is supposed to do. However, we are expecting, there are two things which we will be expecting. That see, some of the time, over enthusiasm should not spoil this. That's number one. So in our hurry or in our anxiety or tackling the emergency the way in which we feel okay. So I remember one of the case when I was at Karamsad, there was two very senior doctors from Baroda Medical, from Vadodara. They were traveling and near Anand, they sort of led up with an accident. And because they were physicians, what they did was that they came to say yes medical college and they were knowing me, they came to me, and when they came, they were holding their neck like this and they came. So it was something very, very good which I felt. So they had developed a seat belt injury, they had a vehicular accident. And why they were holding the neck was because that they were knowing that if the cervical spine injury is there, if we move our neck, it might be that there could be spinal cord injury and we might develop osteoporosis. So in over enthusiasm, sometimes we would be, suppose somebody has taught you in lefty class that you have sort of do head tilt to sort of maintain the airways, and you might be doing that, and you might end up with some problem. So one of the things which we have to do is that we don't have to overindulge. At the same time, we should not lose the golden opportunity or golden time where something could be done. So that is something which I want to sort of clarify. And if you have some doubt, you can ask me, you can input me. And whatever way in which I could be able to explain, I will try to explain the things. So this is it will be an interactive session. We will discuss a common case scenario. So whatever she was trying to say, we are not going to discuss syncope as such, or we are not going to discuss epilepsy as such, or we are not going to discuss diabetic coma as such. So we will be discussing in a form of case scenarios. Opinion may differ, but what we are talking is the most recent and that is evidence based. What Madam was trying to say was that whatever should be there, that should be up to date. Now you might have undergone some sort of training also. And in CPR training also, there are a lot many new things which has come up. So what today what I am trying to say, and then there are certain modifications which have been there. So that also I will be talking about. Next slide. So this is the type of case scenario. You might be sort of having some dental intervention. So you have to assess priority. What is the priority? So many times we take a lot of time in taking the histories and other things. See, in emergency, you don't have to sort of try and feel that okay, we have not taken this history, don't feel guilty about it. at the first moment, what is the priority? That is the first thing which you have to do. And you have to try and say, okay, when and to whom the patient to be referred. It's not only your responsibility. It might happen then, so don't feel shy. And some of the time, say, if I feel that, oh, I'm HOD, I'm professor of medicine, I should not call Hardik. So some of them, the junior people, because they would be doing CPR, the amount of energy which they would be having, a old person like me might not be having. So they might be much better in giving CPR than what I might. But then, see, I might be knowing what exactly is to be done, why that person is being unconscious. So that sort of instruction can be received by the person who knows about this emergency. So all other people. And it's not that you would not be calling the lay people. Sometimes you might require the help of lay people. You have to say that, okay, you ring up ICU, or you ring up the blue code, or you ring up the ambulance services. So you have to take help of non-medical persons also, other people also. Next slide, please. Now, medical emergency in dental practice might not be very common. It is not very frequent. At the same time, whenever it occurs, it will be just like a storm, whatever the title is given. And during this storm, see, you should not become scary about it. Because I know that because that you have done basics, you would be able to do something better than what, say, the person who would not be knowing about medical emergency would be knowing about. Next slide, please. Can you give me the okay. So one of the urgent act is to stabilize the patient. So so it's a case scenario one. I think can you read this case scenario?
30 years old male patient, anxious and having pain phobia with no comorbidity, becomes suddenly unresponsive by tooth extraction. He does not have proper pulse on palpation and no normal breathing. What to do and what can be the cause?
Okay, so say here is a patient. I'm repeating this case scenario. He is anxious. Now, one of the things which we see commonly, and that anxiety also should be coming into picture. So most of the time, see, if I have to go to Dr. Vandana, or I have to go to say to a dental surgeon, I also could become anxious. What exactly is to be done? Whether I would get pain or not, whether my local anesthetic agent would work or not. So person would be anxious, but then there are certain people, like children or people who have comorbidity, they would become more conscious about it. They would become more anxious. So here was a patient, though he was young, he was anxious and having pain phobia. So he said, so when the patient comes, his gestures also would show you that person is phobic. So with no comorbidity, it becomes suddenly unresponsive while to that extraction. So it might happen that young person is being there and patient is anxious. So all the time don't consider that this patient is a psychic or hysterical, and you sort of do not give report. Because this patient, say one of the important things which has been there is he does not have proper pulse. So one of the very important things is that you should know how to examine the pulse. So say I would ask one of the postgraduate students, suppose if you have to examine the pulse, how to examine. Okay. So don't feel shy about it. Huh? So if I ask a question, then yeah. So how would you examine the pulse? Okay. So in emergency, it is a radial pulse which you should be trying to pass. It has to be carotid pulse. So one of the things, see, because that we try to teach you, you are right. We teach you that whenever the pulse is to be taken, with 3 fingers you could be palpating the radial pulse. But in emergency, maybe if you palpate radial pulse, it is okay. But see, if the radial pulse is not being palpated properly, you palpate the carotid pulse. Okay. And what about breathing? What do you try and see? How do you know that the person has a normal breathing or not? What do you do? in emergency. One of the things which you will be trying to look is that whether the chest movement is there or not. Or you go near the patient, put your finger near the nose, and there you will be trying to sort of feel the air is being going inside or not. So that is something which you should be trying to do. Okay. So now anybody would be able to say, what do you do? So what you would be doing? Here is a person where proper pulse and breathing is not in there. What do you do? What is the urgency here? Here you have to go for CPR. Why CPR? Because there is no pulse. If the pulse is not in there, it means person has become unconscious. Patient has become unconscious. That means that blood is not reaching to the brain. This patient might die. Don't consider this patient because that has pain phobia. If you don't do something at this moment, patient might die because he does not have pulse. He does not have proper respiration. So here, one of the important things is that you would be going for CPR. And what could be the cause? The cause could be many. So immediate action is crucial. Begin CPR, that is cardiopulmonary resuscitation. Immediately, priority. So our priority has to be chest compression. Why chest compression? Anybody would be able to answer. Why chest compression should be priority? Because here the patient does not have pulse. And if the pulse is not being there, so what we are trying to say is the cardiac output has decreased. When the cardiac output has decreased, brain does not get enough circulation. And otherwise also in CPR, we were trying to talk about ABC. What we meant by ABC was airway, breathing, and circulation. But nowadays, everywhere, wherever you go, it is CM. So circulation of compression. That is something which is being very, very important. So you would sort of, our priority would be chest compression, simultaneously call for emergency medical services. So call for help, shout, please help. There's a person in a dental board also. Somebody might be there, but see, it might happen. And a senior person or the person who would be knowing about emergency might be a little apart. So when you try and shout for the help might come to you. Or alert a dentist or a trained medical professional on site. See, here you might call somebody from, say, medical pathology. What can be the cause? After stabilization, investigate the patient. The causes could be vasovagal syndrome. Now, though vasovagal syndrome be otherwise is a benign condition. And it might happen with this patient also. The vagus nerve might be excessively stimulated. So whenever the vagus nerve will be excessively stimulated, it might happen that it might lead to bradycardia. It might lead to hypotension. And the patient would go for syncope. However, syncope would remain only for a short while. See, syncope, generally what might happen is that you try and make the patient lie down. Then what might happen is that blood circulation to the brain would improve and the patient will get better. One of the things which you can do in such a case is that when the patient is on the dental chair, he is being quite alert. So what you have to do is that you try to sort of make the dental chair straight so that the circulation to the brain might increase. So that is something. If the vasovagal syncope is there, the postural effect might be there. We don't want putting all the blood to the legs. We want putting all the blood to the brain. So that can be done. It is one of the common cause of fainting, especially in the situation involving anxiety, pain, or fear. This can trigger a sudden drop in heart rate and blood pressure, leading to loss of consciousness. But then here we have to think about something more also. It can be cardiac cause also. So it should not be that you try and say, oh, this is the vasovagal syndrome. And when the cardiac cause is been there, if you start the CPR, if you start the operation, you might save a patient. So cardiac arrest due to arrhythmia, abnormal heart rhythm, heart attacks, or the cardiac issue could be the cause. This can lead to sudden loss of pulse and breathing. The third thing which could be there, it's very common, is medication side effect. So you might have given some medication and that side effect might be there and this other person has become unconscious.
Sir.
Yes, sir.
So with this cardiac events can be, even if the patient is normal, healthy.
You see, cardiac arrest, some of the time what you are trying to see is that the catch leg. For example, now they have sort of a very good, say, vagal tone. Or somebody could be so William's question is very pertinent. So many times we say, that's how the case scenario which I have brought is that here is a young patient, he was anxious, he was phobic. Now, we might consider that this patient sort of would not require cardiac resuscitation. But then, say suppose patient is having ethoscope. That's a type of cardiomyopathy, obstructive cardiomyopathy. Then here sudden cardiac deaths are being known. So it might be that the person might be, even though he could be well and healthy, there's no past comorbidity. That's how the word which I mean. But here, see, the importance is not what is supposed. The importance is that you should start CPR. Like the breathing and circulation will start, patient will get up. Something that is probably is the patient now has improved. So you can try and see for this. Say syncope has a patient change and position change person. Patient all suddenly. But if the patient is having cardiac event, the patient would not gain consciousness. So that could be something which can say medication. The person might develop anaphylaxis and going to come with anaphylactic shock. So if the patient has gone for anaphylactic shock, that was one of the case report which was reported in the journal that the surgeon was sued because she was not being able to sort of find out that it was because of the medication that led to anaphylactic shock. So this might, I don't say this is a very, very rare thing. I'm not trying to scare you people. But then whenever there is no pulse and so there are two situations which might be there. Don't give unnecessary CPR. But when the CPR is necessary, you should be giving. That is something very, very important. So after we make the patient lie down in the visual chair and the patient does not regain consciousness. So it takes time. At least the first thing which you will be starting will be compression. Don't go mouth to mouth breathing. That it can wait. Because if the respiratory center has not got blood, the medulla oblongata, when the blood circulation would start, the patient would become conscious and the respiration also would start. So, skill of proper CPR, all medical paramedical persons should develop, and it can be performed in case of cardiac arrest or unresponsive patient. So, the first thing is that whether the person is responsive. So, how do you look for whether the person is responsive or not? How do you look for that? Generally, don't try sort of blood pressure level so what you should be trying to allow patient. Or you try to sort of give a painful stimulant such that the person strategizes it. So that way you should try and sort of feel that patient is responsive or patient is unresponsive. Verbal stimuli आपको खबर होए तो नाम की बोलाओ मगज भाई केम छो तमे सुन रहे हो तुम then sort of that would be verbal stimuli. But if the verbal stimuli response now, so you give painful stimuli. And that's how you know that the person is unresponsive. So here in such a case, you would be giving CPR. So that is something which we have shown. Next slide, please. When to start CPR? Recognize unresponsive adult with no breathing or no normal breathing. Now, this is also something very, very important. So, agonal gasps. What exactly do we mean by that? Generally, you might have seen the IV patient. I don't know, see, all of you might know, might be knowing Gujarati or not. But what we say is that it is something, it's a type of agonal breathing. Nothing, what is this agonal breathing? The patient would have irregular breathing. The patient would sort of, there will be some voice which will be coming out when the breathing would be there. And it would be labored breathing. As if it has to take a lot of force. And it will come up after some time. Okay, regular breathing or a breathing need. Now, this agonal, if there is a system of agonal gas, then also you should be starting with something. So, agonal gasps are abnormal, infrequent, and gasping breathing that occurs when a person's heart is no longer circulating oxygenated blood effectively. There's it's written a little in a better word, but I wanted to explain, and that's how I say it in a plain words. So, agonal gasps are not true breathing and are often a sign of death, which is imminent. This is a severe medical emergency typically seen in cardiac arrest or in other serious medical events. Because agonal breathing is a sign of severe medical distress, it's essential to call emergency service. So it's not only that you would be doing CPR. With the CPR, you should be calling the emergency service. Call at ICU. Call for the glucose. Immediately and begin CPR. Agonal class are characterized by labored, irregular, and shallow breaths, often accompanied by moaning, grimacing, or other strange vocalization. So, what do you mean by unresponsive patient? With no breathing or abnormal breathing, no pulse, you can use a stethoscope at that moment. So, suppose if you are not getting a proper pulse, carotid pulse is not being there, radial pulse is not being there. If you have a stethoscope, you put a stethoscope and hear the heart sound. And there could not be any heart sound also, or there could be a very sort of strange heart sound which you might be hearing. Some of the time you might be hearing some movement sounds also. When heart sounds are not being there, some abnormal sound or some movement also would produce sound. And there would be a risk. See, whenever it might happen, that person has good pulse, but there is respiratory arrest. So you don't find a good amount of respiration. Just for movement is not being there, but pulse is good. So which would be this condition where the pulse is there, but respiration is not being there. So what we call it as respiratory depression. So you might be seeing a young person who might be sort of taking drugs. Like he might be on say some illicit drugs, heroin, he might be taking morphine, ganja, he might be taking. Now all these agents might produce respiratory depression. Some of the time, if the patient has foreign body, so there the airway management has to be done. So when something is obstructing the airway passage, then also the respiration would not be there. So in such a case, though I say that we have to go for CAB, your airway and breathing, they have to be taken in a more detailed way or more proper way. So as I said, now we have CAB from ABC. Start cardiopulmonary resuscitation. Initiate chest compression before giving rescue breaths. So now circulation is first, and from ABC we have come to CAB. Now ABC and its D also. So we could be coming to D. Here the defibrillator machine is being shown to you. So that is another thing which we are putting here. So from ABC, we have come to CAB. So what is CAB? Compression. When we are doing compression, what we are trying to do? We are trying to improve the heart cardiac output, or we are improving the circulation. The breathing is related to the lungs, and the airway, which is more related to upper respiratory tract. So if the upper respiratory tract has been affected, the patient would have obstructed breathing, and there the airway management is something very, very important. So see, what I want is that everybody should sort of elevate your both the hands. Okay. And now what you would be doing is that try and produce a lobe like this. So the lobe which has been there, what has been shown here. This way you should be trying to. Why you would be trying to do is that here you will be able to apply maximum force. So this is the way in which you will be trying to sort of lock your hand. Now, it comes. So we would be trying to demonstrate let's say how we would be giving compression. So the first aspect which would be there, initial so I might continue my lecture. So what is the technique which is there? During CPR, remember, push hard and push fast. So what exactly we mean by that? As I was trying to say, young person would be able to sort of give, this CPR is something where say you are doing a lot many exercise, or it is very spontaneous. So what you might be trying to do is that whatever sort of compression which you will be giving should be with hard. Now, how much hard it should be? So here the imaging would show a yellow light. If your compression is not being proper, the heart might not be able to push up the blood. So the nerve should go inside to say 2 inches. That means 5 something. So that has to be there when we say push hard and push fast. So normally how much heart rate or pulse rate is there in a minute? How much is the pulse rate? 72 per minute. So it might be 22 and generally that we would be trying to just compression just like a normal heart. So we would be giving compression 100 per minute. So fast means that you will be giving chest compression 100 per minute. So that would be the thing which you will be. So compression rate is at least 100 per minute. If you give more compression, it is good. It's not that say somebody might be sort of 110 or 120. So you give 120 compression, but then the sternum should go inside. So it has to be hard compression inside. As I said, depth of the sternum compression at least 2 inch. Now, what is the compression ventilation ratio? See, generally, as I said, initially we were giving a lot of importance to the. And in physiology, I was being sort of when I was a student, we were say the patient was when the patient is being unconscious to start mouth to mouth breathing. So breathing was given a lot of importance. Airway was given a lot of importance. So here, what is to be done is that we start with the compression first, and the respiration which should be there. That could be say after 40 chest compression, you have to do 2 breaths, and that 2 breaths has to be simultaneous. So this ratio is been very important. So they would be starting 30/2. That is the. So if you in an infant which has been there, because you might be knowing that infant the respiratory rate is more, and if you have another respirator, you might give 50/2. So that could be their exception in physiology. So whenever you will be giving the chest compression, what you have to do is that whenever you are giving the compression, as I said that it should go 2 centimeters down below, and then it should come up. So Ali नीचे down side पर नहीं कर. So whenever we have to count 1 and 2 and 3 and 4, end is being there. 1, 2. In between there is word end. So why that word end is being there is that let the chest recoil up. So it has to come in a normal position. That would be the diastole, and then again to compress where the systole would start. So that is another thing which is very important. Can you start? Yes. So all of the thing is going to be shown. So the hand is being put down here also. See, whenever it should be better that you perform on a hard surface, because your compression should be better. And suppose if you are sitting, what you should be trying to do is kneel like this, and then your hand should not be bending over the wrist. So what you should be trying to do is 1, 2, 3, 4. This way you should be trying to do. Say here we are doing on a table, so there might be little limitation. 1 and 2 and 3. Say here the yellow line has come. That means that whatever the chest compression is being there, that is being correctly done. 1, 2, and 3, and 4, and 5, and 6, and 7, and 8, then 9 and 10. So this way you could have doing 100 per minute. Thank you. And then see after 30, what you should be starting would be say the breathing. So either airway breathing could be done, or you have a move weight. So generally a move weight might be available in at your place also. So you might attend a move weight. So whenever you are trying to put the move, what you might be feeling is that the chest would come up. That is also something which can. And compression relaxation ratio has to be 1:1. Allow complete recoil of the chest. That's it, right? See, you have to perform. Next. You have to perform 5 cycles of compression and ventilation. So 5 cycles means you will be doing 150 sort of chest compression. And this would last for how many minutes? It would be lasting for 1.5 minutes. If you give only chest compression. But here what is been written is for 2 minutes. So about that 30 seconds, what is that time? We are going into trivia, but then this is something very, very important. So that 30 minutes which are in there, that is the time given for rescue breaths. So it's not only that we are doing chest compression, at every 30 chest compression, we are giving 2 sort of rescue breaths. So that would come, and if this has been done, our CPR is say adequate. Next slide, please. So switch the compressor every 2 minutes. Now, if Deepika has been there, she will be doing for 2 minutes, and then later on a 3rd minute, she might feel little fatigue. So it's not that only one person would be in chest compression. If the other person is being there, say now the Hardik would come and he would start doing it. Next slide. So as I said, what you would be trying to say is that don't say 1, 2, 1 and 2 and 3. That way you will be starting with the chest compression. Next slide. So this is the wave. Can you show the part of the wave? So whatever is being tied here, this is a rebreathing mask. So whenever we are giving oxygen, the oxygen would not be wasted and it would be collected in a rebreathing mask. And this is the part of the mask which we will be trying to fit it on the nose and mouth. So that would be there. And whenever you are trying to perform the thing, the weight should be sort of going like this. So if you both the hands are being sort of, if you are doing what you will be trying to do is you will be trying to compress like this. That you will be trying to give. And what she's been trying to hold is that air leak down.
So,
Yeah.
if somebody has the oxygen cylinder at their place, would we use that cylinder at that time and continuous oxygen flow and then compressions along with it?
Yeah, it's a very good question. One of the very important thing is that whenever you have pulse oximeter. So if a patient has got 97% saturation, there is no need of wasting your time trying to see giving oxygen. That is one of the things which I am going to show you in the videos. See the patient's saturation is 97%, there is no need of giving oxygen. And by giving chest compression, by giving just a rescue breath, the patient is going to. So even though you might be able to facilitate for patient relative, it might be that they give started oxygen. But for us, that oxygen is not important. It's the air. It is the respiration which you are starting. That is something we do. So don't waste your time bringing the oxygen solution We have facility in our sort of college, it's okay, but in clinic, if you don't have sort of that. Let's say at the time you might not have used oxygen cylinder for say 3-4 months. And then you can go to a time you are again. So you not open up. So unnecessarily if you are trying to the patient relative also go together. And if you are trying to fumble on that, they would make out. These people don't have that purpose. And it's not a skill which we all have acquired. Because then we have worked in hospital only, a oxygen cylinder it might be difficult for us to open up the oxygen cylinder. Or we might not have that much strength to open up the oxygen cylinder. That is something. So Ambu bed I've already talked about. Next slide, please. So this is a part of the Ambu bed which I've already shown you. Okay. Now, see, now we have been coming to airway management. So we talked about communication, we talked about say breathing, and the third thing which would be there is sort of the airway management. Now, what exactly we mean by airway management? This is something which anesthetists do very often. If the vomitus is being there in the throat, and that is obstructing the pharynx, the air is not being going inside. What we so one of the best way is that the patient does not have any spinal injury. You can make the patient lie down laterally. When you make the patient lie down laterally, the airway would open up. Or what you can do is that you might do what is known as the sort of the you can have a clean lift and the head sort of leg it could be positioned on the lower side so that the airway would open up. Now, as I was trying to say, patient might have spinal injury. Now, here we don't expect that our patient would have spinal injury. But in a vehicular accident, if the patient has got spinal injury, then what we would be trying to do is a jaw thrust. So there you don't sort of tilt the head. So you just have to forward the jaw up so that the tongue is been obstructing the airway passage. So that is the method which can be done. And if you have, if at all you are not being able to, there is another method which can be done. Next slide, please. Next slide, please. Next. So see, this is basically a jaw thrust maneuver. Next slide, please. So this is the maneuver which you can try and go. This might be an easy one. What you have to do is that what you would be trying to do is that you can elevate the head in such a way that this would come in a straight line. So this would also make the airway open up. So there could be airway line. What is this? Anybody knows about this? Pardon?
Middle layer.
Yeah, see, this is basically oropharyngeal airway. And what see why we are trying to press it is that say whenever you are pressing the airway, the tongue and the pharyngeal wall they would remain apart. And this is also it has to be sort of done in such a way that whenever you are trying to sort of press it, then the final position should be such that it should be lying in such a way that the tongue has been sort of like a tongue depression. But you cannot put it like this. What you have to do is that you have to go like this and then rotate 180 degrees and come like this. The position of this also has to be proper. So what you might have to do is that see from the incisor tip to the angle of the mouth. This much length has to be there for this area. The patient is unconscious or post-operative patient. Generally, the one anesthetic is to keep the airway because so there they have anesthetic agent, so the muscle will get relaxed and the airway might compress up. There they try pass this over the injury. Next slide. Next slide, please. Okay, so now See, after ABC, what we will be trying to do is defibrillate. Now, see, when the patient has cardiac arrest, the cardiac arrest, one of the cause could be ventricular tachycardia or defibrillate. Especially, say the patient has vomiting, patient might have hypokalemia, patient might have electrolyte disorder. That also might make a patient to have cardiac arrest. So if the patient does not regain consciousness by your compression, then say whatever your CAB or compression and rest, they should continue. But meanwhile, the patient is not being sort of regaining the consciousness, then you might have to do defibrillation. So A, B, C, and D means so that D part down. See, nowadays, if you go to any public places, go to America or you go to UK, at all public at parks, at say at airports, they have AED machine. She has brought the AED machine, and how the AED machine has to be operated, then also she would be trying to say. And this is something which has been essential. So, previous slide. What is known as it's an old emergency problem. Or we say emergency control. So whatever name. So the crash card, why it's known is that at the time of crashing, this card should be available. And this crash card, maybe it might be having the facility. Laryngoscope is something very, very important. See, they might come for the help. Suppose they need help. And suppose they want to intubate. But then we don't have ET tubes. So see, even though the expert is available, if or anesthetic is available, if you don't have a fresh card, then one of the very important things is that the patient would develop anaphylaxis. Patient might go into shock. So which is the drug which would be very important in anaphylaxis? Adrenaline. So that adrenaline injection should be there in one of the sort of boxes which has been there. So in any of these boxes, it should be there. So the crash card is something which say that the paramedics or the medical places should be. You might have one then say crash card can be brought from say one department to other. Then one crash card has to be there. Next slide, please. So you would demonstrate AED. So exactly the AED is to be. It's very simple. With a person who has never operated also, but you would be more confident to apply AED because you have seen. Okay. So there, the most important thing is that how you would be placing both the pads. So where you would be placing the pads, that is something very, very important. So one of the pads which would be placed would be where the heart is situated. So you would be placing one of the pads in the precordial region, and another pad which would be there on the right shoulder. So this way you will be putting both the pads. And then one of the important thing is that patient who is being drowning, if the water is there, don't give this sort of port. You might have to sort of whenever air or oil or something is in there, you have to wipe out the things. And you have to see in infant because the pad might occupy one of the surface. Maybe that the pad could be interiorly and possible. So one of the papers being put over the sternum and the cardiac region, with the precordial region, other thing would be for. So this way the bed is being formed. If you want to see, then you can see the bed how it is being formed. And then see if I'm touching and the stroke is being given, I also might get a shock. So ask the people to go away. You don't have to touch the patient when the disease shock is being given. So say there would be a recording which you might can give a record.
This is the AD. It's a teaching purpose AD. You have to actually see the AD. You can visit our railway station, Vadodara railway station, Vadodara and Vadodara bus stand and malls. So first step is every machine you have to use. First you have to on. So this number should flash in every AD. Every AD has a universal steps. So first step is the power on.
So we are charging. So this would be
Patients their chest, plug in current connector next to flashing light.
So first step is power on. Second step is apply the patch, and third is the attach the connector.
Now, analyze the
You can analyze the rhythm. You do not touch the patient.
see here,
Advised.
our say defibrillator machine would have a monitor, and you might find tachycardia, ventricular tachycardia or ventricular fibrillation.
Press the orange
So there are
button
two types.
now.
Okay, whenever you stop, make sure no one can touch the patient. All clear, eye clear, deliver the.
Start CPR.
See, once you have given a DC shock, don't wait whether the patient, see, you start the CPR. And then see, it might happen that the patient might improve, patient might not improve. So you might have to give a second stroke also. So maybe you might give 3 or 4 strokes, so the patient is not improving, then you continue your till, say, there are services which are being available. Say you should continue CPR till the patient reaches to the hospital. So that is something which would be important. So generally, say, when we talk about defibrillation, there are two types of defibrillators which have been available. One is synchronous and other is non-synchronous. See, in a ventricular fibrillation, because if the heart rate is very high, generally, see, in AED machine, it does not matter whether you do synchronized or non-synchronized. Nowadays, our IC, they would be having synchronized sort of defibrillator. What we mean by synchronized defibrillator is that the PQR is complex. The say shock should not fall on T. If it falls on T, it itself might give rise to ventricular. So what we want is that it should fall from QRS component. That would be one of the type of defibrillator machine which is available. There are another thing which might be there. The defibrillator could be monophasic or it could be biphasic. So in monophasic, the current passes only on one end, while biphasic it would be passing both inwards and outwards. So there, even though the energy which we might have to give, so generally this we would give a shock of 360 joules. When you give more energy, maybe patient might develop burns also. So complication rate would be more when you give more energy. In biphasic defibrillator, you might give 160 joules and they could be good. That is advantage of biphasic. So biphasic as such might be more advantage. Of course, the advantage is not very great, but it is the advantage is more technically advanced than monophasic. I think this might be good enough as far as defibrillator is concerned. Next slide, please. Okay, so maybe we will be coming to second case. Okay. So now we are coming to case scenario 2. So what do you find here? This is your basically domain. What do you find? Okay, so there is gum hypertrophy, gingival hypertrophy which will be there. So what would be the cause? Okay, so one could be hypertensive drugs which might be causing it. Or as we say, it could be treatment. So which is common in the drug? Okay, so let us come to this patient has come to you for gum problem and loses consciousness in a dental care. What is your impression? What is your impression? Now this patient would lose consciousness. It's not as serious as what we were trying to talk about earlier. So what would be the cause of consciousness here? This one. Because then you know a patient has come up for aesthetic purpose. Yes, she has a gum hypertrophy. She has come to you. But on a dental chair, the patient would develop, he would develop chronic fits. So don't get scared. So here you know that the patient has got epilepsy. What history you would be asking? So you would be asking history, as you say, you would be asking history of penumbra. What do you do? What have you to do? So I would be trying to show you a video where I would. So the first video is a bit more simple. It's more simpler. It's not related to the dental condition, but you would get the first aid measures. What exactly you would do, and this is why I have put this video. So play the video.
Guys, for some reason, he's having a seizure. Get me some towels. Okay. Stay calm, it's gonna be fine. Help me get him on his side. All right, listen up, fellas. Before we practice, I want to go over a couple of things. First, I'd like to welcome back Michael. Good to have you back. We all know Michael has epilepsy, and he shared his seizure with us in the game. He has something he wants to say.
Yeah, thank you all for supporting me, and thanks to coach for knowing what to do. I'm sorry if my seizure scared you guys. It could be scary for me too. But what's even more scary is if people didn't know what to do.
So today, we are going to learn seizure first aid thanks to the Epilepsy Foundation. We're teammates, right? We take care of one another, we count on one another, and when anyone with epilepsy has a seizure in front of you, they're your teammate. And they're counting on you. So first, stay with it. Okay, stay calm and keep others around you calm and out of the way. Protect him, keep him safe. It's also important to remember that the person having the seizure should be lying down and that there is nothing harmful in their way. Turn them on their side and support their head so that they're not banging it, or so they don't choke. Never put anything in their mouths and do not hold them down. Time the seizure till the very end. Okay. Knowing how long the seizure lasts is important information for the doctors to know. If the seizure lasts more than 5 minutes, call 911. When you see somebody having a seizure, you're going to feel a little powerless. But if you protect them, and if you stick with them by their side, you're doing the right thing. Okay? All right, let's practice this. Put on the 3. 1, 2, 3, 4. Go.
Anybody would be able to repeat, what are the important messages supposed to be included here? Yeah. The number one is that, as it happened with this case, generally it could be self-healing. So if it's been less than 5 minutes, it's basically a benign. And you are not going to do anything, say, you don't have to give, say, diazepam or anti-epileptic drug when the patient gets the service. There is no emergency drug you should do. But you just remain nearby the patient. That was something which was shown here. You have to remain calm and you have to jot down how much time it took. Suppose it's more than 5 minutes, might happen that patient gets seizure. So then a medical help may be needed, or the patient should be referred to a neurologist or to a ICU or to a physician who will be dealing with surgeries. Otherwise, what would happen is that they also know, they might be getting some sort of a headache and the headache could be aborted. Don't put anything in the mouth. So what I have seen is that whenever some sort of headache would come up, somebody would come up with their shoe and try to make them sort of throw sugar. That is, or they might go with ammonia and try to make smell of ammonia. Now, this sort of thing should not be done. Your airway management, of course, the drug might fall back. It might happen. But you cannot open up the mouth, don't do that, otherwise, if you force me, don't do it, otherwise you yourself will get hurt. So if the patient is having convulsion, don't put your hand on his head. Sometimes it will get so much that you will get up also. So don't restrain, that was another thing which was sort of, don't put anything in the mouth. The only thing which they have shown was that the patient was nervous danger. And there was something which they put it under the head. Because if the head, they could be chronic convulsion, they might bang their head and they should not develop skull injury. That was something which they did. Now, say really, we would have say in part 2, we would be trying to show you a real case scenario of such sort of case which had come up with dental and how the dental surgeon was trying to take it out. But it's little more complicated. The English is also not sort of very easy to be whatever way in which you will be able to that we might be doing it in the second. So we sort of help the first part and then after how much time you will 15 minutes, come again here and you will be starting with the part.
Thank you so much, sir, for such an insightful and informative session. We will take a short break of 15 minutes. Refreshments are there outside the hall. And request everyone to kindly join us here.
Please be back in 15 minutes. और प्लीज आपको ढूंढना ना पड़े सेकंड सेशन में ज्यादा मजा आएगा ये लाइव काउंट कर रहे प्लीज जॉइन एक्चुअली आप क्वेश्चन एक्चुअली बड़ा But you
Please stand.